Hi, I am Dr. Deeksha Pandey, Additional Professor in the Department of Obstetrics and Gynae and also in charge of Subdivision of Urogynecology right now. So as in our earlier video, many of you have requested to discuss more in detail about the choice of instrument, the choice of suture material. So we are going to start today a new series of instrument, suture material and some tips and tricks which we can discuss outside the OT. First discussion, we have chosen the topic of tension-free vaginal tape by obturator approach. And I think we have a very pretty person with us to discuss that. She's our second year resident and her name is Dr. Priya Patil. She has done multiple videos before also in our channel. So Priya.
Hello everyone. So we place the patient in lithotomy and then this Foley's catheter is inserted. Without inflating the bulb of the Foley's catheter, we inject 200 to 250 ml of saline, and this is done to check the presence and the severity of SUI. It is very important to note this finding on the OT table so that we know how much to repair and how to approach the patient.
So how do you do that? You fill the bladder with 200-250 ml of saline, you said. Then what do you tell?
Then we remove the Foley's catheter and ask the patient to cough.
And if by chance, because of other related procedures, by chance for any reason, if patient is under general anesthesia, can you still perform this test?
Yes, we can perform this test by mimicking the action of cough reflex. That is, give suprapubic pressure intermittently and check for leak of the urine.
So I want to know one more thing, Priya, that you said that you want to use Foley's catheter.
Yes,
can we use metal catheter or K91, all those kind of things?
Ma'am, metal catheters are usually traumatic, so we would prefer a rubber catheter. And this advantage of Foley's is we can use this to drain urine and keep the bladder empty.
So you don't have to open 2-3 kind of catheters. So one catheter only, which you can use now for some time, and later you can post-operative period, patient can go to the ward with the same thing. Then you said that you want to use this syringe, that is 50 cc syringe. By chance I am operating and I don't have a 50 cc syringe. Should I take the trouble of getting a 50 cc syringe only, or I can do it with 5 or 10 cc syringe also?
We need 50 cc, ma'am, because we are using this portion of the Foley's to inject saline. And a 10 cc or a 20 cc won't fit well, and there will be leak.
Yes.
And also it will be very cumbersome to inject 200 to 250
so many times.
Saline,
so if you are using the syringe, you just have to do it 4 to 5 times. So perfectly use it. So remember Foley's catheter first thing. Second thing is 50 cc syringe. Then what next?
Then after we have established how much stress urinary incontinence there is in the patient, we put back our catheter and then inject the Foley's bulb and keep it in situ.
As a self-retaining catheter, we keep it so that the bladder remains empty throughout the procedure.
Yes. Then it is important to locate where the incision should be in the patient. So what we do is, this is the urethral opening. So 1 centimeter below the external urethral opening, and the incision will be 1 centimeter long. This is done because female urethra is considered to be 3 centimeter long. So we are going to avoid the proximal and the distal urethra and going for the mid-urethra.
So that's why the other name for tension-free vaginal tape is
mid-urethral tape.
Mid-urethral tapes, yes. So what instrument you use to retract how many retractors you use?
This is one retractor. Sim speculum, one retractor will be enough, and we will be retracting the posterior vaginal wall in this manner. And the anterior vaginal wall, with using Alice forceps, we will be holding it 1 centimeter below the urethral opening.
So 2 Alice you need, good grip Alice forceps, 2 in number, to hold one at 1 centimeter from the urethra. The second one is 1 centimeter from this. Okay.
So that we know the extent of the incision to be given. Yes. After planning the incision, to create a bloodless field of surgery, we will be infiltrating adrenaline. This is 1 ml ampule, which is 1:1000 dilution. We take 1 ml of this and dilute it in 200 ml NS.
So 1 ml of adrenaline and 200 ml. This is what we routinely practice. Yes. And if the patient is hypertensive, if there is some cardiac problem, you can even use one of this ampule in around 400 ml of saline. That will be diluted. But usually for 90% of our cases, we are using what Priya said, one ampule in 200 ml of normal saline. Please remember.
So where do we inject it? So once we have planned an incision, we inject the adrenaline using a 10 cc syringe in the center and then laterally, so that we are obtaining complete bloodless field of surgery.
Yes.
Incision can be given by using a 11 number blade. Why only 11 number is because this blade is used for stab incisions. The tip is very sharp. Usually, routinely, we use 22 number blades in our routine LSCS or other gynac surgeries. But 11 number blade, why only 11? We will discuss it in the later part. But this is BP handle, so we fix the 11 number blade to the BP handle, and the incision can be given by the blade. Another alternate method, which is more used nowadays, is by using cautery. This will also help us achieve hemostasis by coagulation.
So monopolar cautery, usually we try to give the incision with monopolar cautery, 1 centimeter long incision in entire vaginal wall. Yes.
So once the incision is given using a cautery or a blade, 1 centimeter, then you hold the Alice in the 2 flaps and retract it. Then ideally a long tissue cutting scissors should be used, and the tissues are dissected by keeping your hands and supporting it, and then you will insert it inside and slowly dissect it without damaging the surrounding tissues a lot, and in this manner laterally and upwards
in a direction of 45 degrees. You can use any landmark. You can say towards the shoulder of the patient in 45 degrees towards the obturator membrane, but slowly you learn that it is around 45 degree angle. So the important thing, the characteristic of scissors is that it should not be very broad. It should be long and thin and sharp scissors, okay, because we have to just create, most of the times we just have to open and close. Initial cutting of fibers when we do, then it creates, there is loose areolar tissue, and just opening and closing like this is good enough. So the scissors, the size of scissors should not be too broad. That is what matters. Then
after that, once you have dissected adequately, now we have to exteriorly locate the points of where the helical trocar is inserted. These are helical trocars.
So before opening, just show the stab wound. Where will you make the stab incision? Don't open, just with this, you locate the place there.
Using a BP handle and a 11 number blade, as I said before, a stab wound is created at the level of the adductor longus muscle insertion. Usually it is at the groin level, but it is very painful for the patient, so we'll go a little laterally, and then exactly here I make a stab incision. And what is the other way to know that you're right is it corresponds to the lever of clitoris. So bilaterally we make an incision, a stab incision at the insertion of adductor longus muscle.
So wherever we want to make a stab incision, the only, you can say best, but I will say the only blade we have a number, many numbers of blades, but only blade which is used for stab incision is
11 number.
Where else we use this in gynecology?
We use this also to create ports
in
laparoscopy.
laparoscopy. So laparoscopy also, when you have to put Verey's needle, then you have to create a 5 mm, 10 mm ports, we use that 11 number. So that's the important use in gynecology for 11 number blade.
And then these are the helical trocars.
Are they disposable trocars?
No, ma'am. We usually gas sterilize them or autoclave them, and it can be used for multiple patients.
So it is just a one-time purchase. The set costs you around less than 10,000 rupees, and this set is by Lotus Surgicals, and we use their set only. Since many years we have been using it. Open it and then I'll show you that. So it is gas sterilized, and then these are two, one for right and one for left. You need two because the curve is in a different way, and the tip is very sharp. So they always cover the tip with the plastic tube. And what we do in 2-3 years, when you do many these kind of procedure, we feel that the tip has become little blunt. So we just give it for sharpening, and again we can, for I think for last 10 years, we have 2-3 sets and we are using the same set. It's a very good investment. So it is reusable set which we are using for trocars. Okay.
Makes it cost effective for the patient as well.
Yes. So can you tell me that which one is right side and which one is the left side?
This one is the right, like it goes in my right hand, and this will go in the left side.
So if you are not smart as Priya, what you can do, you can just read it. It's written here. Notice this is left side for L and this is right side. Her technique is better, we always do that. But if you get any confusion, it's actually written which is for left side and which is for right side. Okay, then what happens, Priya? So if you want to see, these are called helical trocars. It has a straight stem and a curved this thing. Only problem which I find in doing this is, I think they should have innovated it for different women's size. Okay, we get this is only in one size. So sometimes, as we have previously discussed also, it is very tough if the patient is very obese. Okay, the length, this curve is not enough. So maybe they should have another version for obese patients. So obese patient, we are not using this technique for that reason only, because sometimes we had a lot of difficulty in OT table in negotiating these needles. So we are using retropubic tape for those patients, which we will discuss in our next session. So this, how it works now, tell me. How you put it?
We already have given a stab.
I think you can remove this. Yes, so gently it will hurt you.
So this is the helical trocar, and it has a very sharp end, as ma'am told, and it also has a needle eye. So we have already given a stab incision before, and in that stab incision, we are supposed to nick the helical trocar, and with my other hand, wherever we have given the mid-urethral incision, my finger will go, and then once we insert it inside, I have to feel the edge of the trocar in my tip of the finger, and I'm going to apply pressure here with my thumb, and then we insert it. Once we feel the loss of resistance at the obturator membrane, you curve the helical trocar so that it goes towards the finger, and then the needle of the tip of the helical trocar will come out of the incision. This has to be a circle.
This is a very important understanding. So half the circle it is, they have given you, half circle you have to make with your hand. So when your finger is trying to get this needle through the tunnel, this thumb should push this part of the trocar so that there is a circle. The thing rotates, the trocar rotates in a circle. So I'll show you again. This is the helix. This has half circle here. I put my finger of the left hand, index finger, into the tunnel which I have created, and I give a gentle pressure to this part of the helical trocar so that it gently rotates, and then I can feel. This is one circle. This you have to remember, half circle with your hand and half circle with the middle trocar. That's what is the trick. To entire trick lies in this blind procedure. This is the entire trick. Okay.
Once we obtained the end of the trocar through our mid-urethral incision, this,
you can keep it down and show this now.
This is the tape which we were talking about. We can imagine it as a mesh, a long thin mesh.
It is by Lotus Surgicals. It is called Trans-Obturator Sling System. And the cost of this is how much?
Around 6,000 rupees. This is not a reusable. We put this inside the patient. So patient will have to bear this price. So this is 6,000 rupees. So this, for our imagination, because I hadn't seen a tape before. So for all the postgraduates out there, this is nothing but a mesh. We have might have in our internship seen for umbilical hernia a mesh. Imagine that is cut in a longitudinal long piece. So this tape once, and the tape can tape is flexible, the mesh is flexible, so this has to go inside this needle eye as I showed. So the instrument is placed in this way inside the vagina, and we insert the tip of the tape through the needle eye and then put an artery to this end, so that we know till where we are taking it out. So usually the artery is put at the center of the tape. Okay, so once everything is set, we take it out in the same way how we have gotten it, so that the mesh is coming outside the skin. Okay, and then we remove the helical trocar and then place the artery and then leave it there. So this does require a lot of imagination, but this video will definitely help you before you go to watch a real surgery, and you can impress your staff as well.
Okay.
So the same thing is done on the other side. Okay, the other side of the helical.
So because it is very sharp, so whenever it is not used or it is given for autoclaving, sisters put a plastic sheet, they fix it very tightly. So you have to remove this before the surgery.
So other side of the trocar is taken in the same direction. This I will be able to show you guys better, I guess. So the stab incision wherever we have put. Okay, so my one index finger goes inside, and then to support the other end to meet the circle, and my thumb will give pressure to this end so that it is placed and the angulation is right, and so that it comes out with ease. So this finger, my index finger, will act as a guide. Okay, and this will act as a pressure supporter. So this will be the circle we are creating. So once this is come out, so we take the other end of the mesh and then place it inside this needle eye and then take it out of the skin. So we have still placed our artery in the middle of the mesh, if you guys remember. So once this and this side of the mesh is out, we have to know how much to tighten it or loosen it, or if we are at the right place for closing. And how is that done? We repeat the same process how we started initially.
So usually when you are doing the tape, you can just put the tape in place with the help of an artery forceps or right angle or a Mayo scissor. Actually, they say that Mayo scissor is the best because the tape should not be tight. If you put it too tight, it will cause obstruction. So tape should be loosely lying below the mid-urethra, so that normally it is just there, loose, very loose, but when the patient coughs, the tape gets pulled up. That is the mechanism how it works. So when you put a tape there, you always should put an artery there to check that tape is loose enough or not. If in the initial days, what you can do, you can put a scissors there, Mayo scissor, or what we call as our suture cutting scissor, which is like little thicker in size. You can put and see that tape should be loosely fit just below the urethra. It should not be tightly or snugly hugging the urethra. That's very important. Then once you have adjusted the tape, then what do? You were saying some test that we can do.
We can repeat the same process. So as we remember, the Foley's catheter is already in situ. So we take the 50 ml syringe again and fill the bladder with 200 to 250 ml syringe and ask the patient to cough again. So this will help us realize if she has SUI or it is fine. Always notice that patient should have 2 to 3 drops of dribbling when we check for adjusting the tape, because otherwise she can have urinary retention.
When she comes out of spinal anesthesia, her muscles will be more active and will have more tone. So in that situation, if the patient, that tapes, the same tape can be tighter. So as a rule, patient should, when she's under spinal anesthesia, after you have perfectly put the tape and adjusted it, the patient should be able to leak 2 to 3 drops of urine on cough.
Once we achieve suitable amount of tension, we can go ahead with vaginal closure. Anterior vaginal wall is closed with monocryl. This is a self-absorbable suture, and it can be closed in continuous interlocking sutures.
Or not interlocking. If the edge is bleeding, then I always tell that use minimal locking when you are putting the continuous suture. If the edge is bleeding, then only for the purpose of hemostasis you should lock. Otherwise, the closure is much better in running in necrosis, and unnecessary stress on tissue should not be there. So what Priya told, that you can use any, it is a small incision, and any absorbable suture is fine. Usually we use monocryl. If you want, you can use the same vicryl rapid which you use to close episiotomy. Or if you don't have that, don't worry, just some absorbable. Even I think vicryl or cadpet, whatever absorbable suture. You should not use very long, very delayed absorbable suture like PDS, or non-absorbable suture like proline, because if they remain, the knots remain in the vagina, there is chance that they will act like foreign body, and they will act like nidus and get infected because of vaginal flora there. So anything you can use either monocryl, you can use either vicryl rapid or normal blue colored vicryl also. And the thickness should not be very thick. 20 is the perfect vicryl number, because the needle is small and it handles the vagina nicely. You won't get many cut throughs there. So this is what we do. And even 30 Priya has got, I don't mind. 30 also you can use to close. Okay, so suture is only thing you have to remember, that it should be in a small needle, and it should be rapidly absorbing suture.
So once that is done, so remember that we had kept arteries here to hold the mesh, and we do not cut the mesh as of now. There are people who immediately cut the mesh and then tape the skin, but what Deeksha ma'am has taught us, or what I have seen ma'am do, is that she does not cut the tapes immediately. So why, we will tell you. So this tape can be closed, like folded in the folded manner. This one stab incision does not require any closure. So we can just put a tegaderm, a small tegaderm, and leave it. So post-operatively, the next day, what we do is we remove the catheter and ask the patient to void. And we ask the patient if she has any symptoms, any urinary retention is documented, or any poor stream of urine is documented. So we use post-operative day 1 for subjective analysis, and the next day we call the patient for objective analysis. So we ask the patient to completely void her bladder and check for residual urine. So if the residual urine is less than 100 ml, then we have achieved the correct amount of tension. But in case the residual urine is more, then we adjust the tape and loosen it a little bit.
Yeah, put her, actually this is not a dilator, that we have just kept her OT instruments for post-operative day 2. You can just put a Hagas dilator till mid-urethra. You don't have to go all the way to the bladder, and just mid-urethra you reach, you will feel a resistance, and just press it 2-3 times like this down, and the tape, it is loosely placed there, so it will just unfold. And we have done it in many cases. You don't have to open the incision, just pull it a little down, the tape gets pulled. By chance, Priya, the patient is having still incontinence. You did it, but patient says that it is reduced from before, but I'm still incontinent. That means there is failure of procedure. Can you do something?
So what we can do is by simply by pulling the mesh out, we will be increasing the tension. So that also can be done by just pulling the two mesh outside a little bit, and then we will repeat the same procedure, as we'll ask the patient to void, or if she has any complaints. And once we have achieved the amount of tension correction we require, and that time you can cut the tape. We have to keep in mind that, as I said, the stab wound does not require any closure. So we do not want the mesh tape to be seen outside. One, there will be a chance of infection. The other, it is uncomfortable for the patient. So what we have to do is, we press the skin a little bit and then cut it at the nick of the skin. And once we release, the skin will come up and the mesh will go down. So the mesh is not seen outside the skin.
And do you have to suture that stem? No.
There is not.
Just put a handiplast or some tegaderm or something and send the patient home. That's it.
So to demonstrate how the tape transverses, we here have a model for you. So here we have given a stab incision, as you remember, and then when we insert the trocar, I will be removing the skin and the muscle layer. So imagine the skin and the muscle layer is pierced. So this is an obturator membrane. So the obturator membrane also is pierced, and then with the help of your index finger, so we get it out in the urethral incision. So once that is done, this we'll consider as a tape. So this ideally has to go through this needle, but for practical purposes I'm going to pierce it. So using that, I'm going to retract back the tape from the skin. So in the middle, I'm going to put an artery to understand what the middle of the tape is. Okay. Once that is done, I take the other side of the trocar and then do the same thing. So this obturator membrane is pierced. That is the loss of resistance we feel. And on the other side, you are going to place the trocar and the incision which we have given in the mid-urethra, and then the tape is removed out. Okay, so when we are understanding that if the incision is loose or not, we take a scissor and then dip it here and see if it is loose enough or not. So the whole mechanism is, if you want more tension, you're going to tighten it, or else you're going to place a dilator inside the urethral meatus and then dip it back. I hope this has made your understanding better.
Now we have given you so much information. We plan to discuss only the instruments part. So what we are going to do, I'll pick up one instrument and I'll ask Priya that why do we use and which step we use it. Are you ready, Priya? Okay. So tell me, what is this?
This is adrenaline, which is used to infiltrate the vaginal wall to create a bloodless field of surgery.
Bloodless field adrenaline, and it creates a better plane also, hydrodissection also. And what is the concentration? Can you tell it again?
This is 1 ml adrenaline. So we use this 1 ml and dilute it with 200 ml NS, and this dilution is 1:1000.
Very good. So this is an artery forceps. Do you need artery forceps?
We
to
need
catch hold the tissues?
No, usually to catch hold of the mesh.
We usually use 3 arteries. One to delineate the midpoint, and when we are taking out the mesh, as Priya has told, to put so that it remains in place. By mistake, in hurry, somebody might pull, and the time you have taken to put the mesh inside and trocar inside, that gets wasted. So 2 at the end and 1 at the center. Okay. Then Alice, what do you use the Alice for? How many Alice? Usually 2 Alice.
Alice we require. This is for the tissue holding. Initially to make an incision to delineate
so these 2 will be 1 centimeter apart in the mid-urethra. Very good. And which blade you want to use?
Number 11.
Number 11, because we have to, important thing that we have to give stab wounds here, and the same you can use to cut the vagina also. Can you use anything else to cut the vagina into your vagina?
Cautery.
Very good. So
monopolar
most of the times we use monopolar cautery to create, as Priya said, a bloodless field. Okay. Then tell me, this forceps you have got for what?
Just to adjust this thing.
Or to hold the skin while you are suturing. Okay, so while suturing, this is monocryl. You can. What is the alternate for vaginal
Bicryl 20. Any rapid absorbable suture can be used.
Yes. You have got this one injection also. What's that tagline?
This is a prophylactic dose of antibiotic we would like to give.
Believe me, only 1 injection, half an hour pre-procedure is enough for this procedure. Actually, you do not need to give any more antibiotic in the post-op period for this patient. Okay? This is the speculum we need to see the antevaginal wall
by retracting the posterior vaginal wall. This is SIMS, as we all know.
Yes. And these are the 2 helical trocars, most important instrument. And again, I'll tell you that these are reusable,
gas
sterilized and used. They have very sharp ends, so you should not try to play with them. And whenever it starts getting blunt, we give it for sharpening. So we have been using the same set for years and years, and still it doesn't bend. I don't know what metal they are made. They're very good. Okay, it is by Lotus Surgicals. And how do you know? You can just have an idea also. That's open side should be towards the vagina. That's how you delineate that right side and left side, because both the trachars are different. But if you want to confirm, and if you want the easier trick, it's written here L for left side and R for right side. Okay. So how do you do that? Priya has already told the most important trick. If you tell me what is during this procedure, as she has explained, making a circle. Half circle by this, half circle. One finger will remain in the vagina, and this will push this heel of the trocar towards anteriorly, so that a circle is complete. Okay. I think we have explained you everything. Then anything
Mesh.
this mesh she wants to show it properly. Okay. So this is a mesh. I do not like many people. I have heard that they use the hernia mesh and they cut it into long pieces and try to do this. But you have to understand, though the look is same, but hernia mesh is much stronger. It is much finer kind of mesh, and when you are putting it for hernia in the abdomen, you get to cover it with thick abdominal wall. When you are putting in the vagina, very thin layer of vaginal tissue are there, and because of sexual activity, there is chance that it will get eroded against the vaginal wall. So the chances of erosion are much higher if you use the thicker mesh. This mesh is actually very thin and soft, so we usually prefer to use meshes which are specially made for these kind of procedure, not cutting and trimming and making it that will become much more cost effective, but at what cost? Patient will come back with erosion. So just spend 5,000, 6,000 rupees in this mesh and have a good recovery. I think like this we have explained all the instruments. I hope it works. We are going to put up a list of instruments at the end of this session, and I hope before going to every OT you can just go and check that everything is ready or not. And if you feel any doubt or any question about any of the instruments or even any of the steps that you did not understand, please feel free to leave a comment below. We'll try to answer all your queries as soon as possible.
So I hope you have at least got a gist of TVT, if not the whole procedure. And I'm sure ma'am will upload the procedures.
Yeah. We have actually uploaded 2 videos on TVT.
You can actually go back and see them. Once you see these videos and the instruments, you feel better prepared for the OT, and I'm sure all of it will be appreciated. Yeah.
To answer it in exam also. Okay. So thank you so much.
Thank you.